Well, I'm Tom Aquisto. I'm an interventional radiologist here at Ingalls. And hi, Sharon. I didn't see you there. And you know, I've been here a while. Not as long as Dr. Kozlov has, but you know, almost. And as Dr. Kozlov said, we really like to do things here as a team. I think it's the best approach. And he used the phrase comprehensive cancer care, and it really is true. I mean, it requires multiple disciplines working together. Interventional oncology is a term that's more commonly used these days. It's part of my field of interventional radiology, and interventional radiology is a field that some of you may have never heard of before, but it involves basically doing surgical procedures under image guidance, and the idea is to try to be as minimally invasive as possible. So we do a variety of things related to blood vessels, bile ducts, any pathway in the body that we can utilize to get to a place and do a surgical-like job without making a big incision. So part of the things we do within the world of oncology are things like putting in ports for chemotherapy, placing catheters into fluid in the abdomen or in the chest, putting in feeding tubes, putting in filters to prevent blood clots from traveling places, and actually treating patients, treating the cancer itself with what's called local regional therapy, things that involve going through the arteries, and I don't know if, yeah, this is working, going through the arteries in a transarterial fashion to block up arteries that supply these tumors, or inject chemotherapy directly into the tumors, or inject radiation beads, SIR spheres, Y90 into the tumors. Also, we guide needles or probes into the tumors and ablate them. Dr. Kozlov alluded to something called RFA, radio frequency ablation. It's heating up the tumors directly. You can do the same thing with a microwave process, or freezing the tumors, something we call cryo ablation. Different tumors react differently to these different methods. We're focusing today on cancers of the liver. Cancers of the liver are some of the most common cancers throughout the world, and the liver is a very common place where other primary cancers metastasize to, and primary cancers of the liver are becoming more and more common with more and more increase in hepatitis B and C throughout the world. That is risk factor for primary liver cancers. With the liver specifically, systemic chemotherapy and external beam radiation can often be less effective. The liver is a little more difficult to treat sometimes, and surgical resection is, as Dr. Kozlov alluded to, the best treatment for most cancers. In the liver, often, you know, because the disease process involves so much of it, patients are not resectable candidates. That's where things like systemic chemotherapy and more targeted therapies come into play. This little cartoon depiction depicts sort of why the cancers, particularly of the colon, tend to go to the liver. There's a lot of veins that drain from the colon and go directly to the liver, the portal vein, and cancers that originate here in the colon can end up traveling there quite easily. And this is an example of a CAT scan of a patient that has all these little dark spots throughout the liver here. Those are all cancerous lesions from the colon. So liver-directed therapy itself, I alluded to. We can go through the skin with a probe, freezing or heating one of these tumors, or we could go through the arteries directly and take out the blood supply, or administer chemo or radiation beads. And here's an example of some of those probes that we use. These go directly into the tumors through the liver. There's different shapes and sizes depending on the size of the tumor and its shape. We match it up to see what's best, and this is kind of diagram here of an example. It's kind of a nice cartoon of, this is an ultrasound machine, this is the probe, of course the patient. Here's an ultrasound image of the liver and the tumor inside the liver, and here was the patient's CAT scan before the procedure, where you see this low density area here in the liver. That's the patient's tumor, and then after the procedure you see it's really dark here. That's all dead tissue with a nice rim of margin around it. So that was an effective treatment for that, and that was with a radiofrequency ablation example. Here's another example of a tumor in the liver. This white stuff here is this enhancing contrast material. You can see it in the vein here that many of you may have had an injection of contrast during a CAT scan. And this is the tumor lighting up, and this is the tumor after the radiofrequency ablation. You just see this big dark hole, which is dead tissue, and this minimal rim of enhancement around, which is just reactive tissue. It's not tumor, it's just commonly the liver scarring around the area. Another patient here also showing an enhancing tumor, and the area here, this is before and after, again, big dark hole. So that's the result we like to see. This is an actual depiction of, this is the cancer, this is the probe itself in CT, real time. That's the probe going in. This is just a few minutes afterwards where you get the nice dark spot, and this is a week later where you just get that vacuum. The problem with ablation is it works great for tumors that are less than 3 centimeters in diameter. When they start to get towards 4 centimeters, it still works pretty good, but the bigger they get, the harder it is to treat them, because you end up missing little parts of the tumor around the outside. So it also depends on the location, where they are in relation to blood vessels, where they are related to the diaphragm, can affect the treatment. It's just a little... yeah, I love this picture, actually. This guy is this guy is so cool. So in a case like this that I had showed earlier, you know, ablation is just, unfortunately, it can't be done. There's no way you could sit there and go through every one of these and be able to ablate all these. So another way to approach it is through the arteries. So the unique part about the liver is that it has a dual blood supply. It gets about 70% or more of its blood from the portal vein, and it gets about 20 to 30% of its blood from the arteries, the hepatic arteries. So it turns out that tumors of the liver get about 100% of their blood supply from the arteries, mostly the hepatic arteries. So if you inject things like chemo or radioactive microspheres, spheres into the tumors, you take advantage of that blood supply. So here's a cartoon depiction of the liver, left and right lobes of the liver, the portal vein, left and right branches of the portal vein, and the tumor, and you can see the cartoons getting this tumor is getting all its blood supply from the arteries in red, not the vein. So what we do is we go through the arteries by accessing the groin artery down here, similar fashion to the cardiologist when they do an angiogram of the heart. We go in the same spot. We get a little tube called a catheter. We get up into the arteries of the liver, and we inject either chemotherapy or these radiation spheres. With chemotherapy, we're able to use very high concentrations of chemo, certain types of chemo, that go directly into the arteries that supply the tumors. They have less of a systemic effect. If you use that same concentration throughout the body, as Dr. Kozlov gives, you would have a lot more problems because we're able to concentrate it in one area. We block off some of the little micro vessels after we put in the chemo, we block off the microvessels with some little particles, and it helps to prevent chemo from being diluted out of the area. So it allows us to treat multiple areas at one time. So here is an example of a tumor, and this, I apologize because this thing isn't working very well, but here is the tumor right here. I don't know how well it projects. It's not projecting as well as on my screen, but it's right here. It's that darker area. And here is an angiogram. So most of you probably haven't seen angiograms before, but this is a catheter, and this is contrast in the arteries of the mid-abdomen. So this is the artery that goes up to the liver, and this area over here is the tumor. And by getting a catheter way out into the artery that supplies this tumor, we can inject the chemotherapy, and we mix it with a contrast solution so it sticks in there, and you can see that's all chemo embedded in that tumor, and that's termed chemo embolization. Here's another image of a patient with primary liver cancer. This is the liver cancer right here. This is the liver. This is the angiogram. You can see the large artery going to the liver and these branch arteries feeding this tumor. And this is afterwards. This is that white spot is now that contrast and chemo that we mix together in the lesion. So other than chemo, we have this radioactive device called Spheres. This selective internal radiation therapy is what the term is. And the idea here is, instead of injecting chemo, inject little particles that contain very high doses of radiation. And the idea is to selectively target the radiation and have that radiation high enough to kill the tumor cells, but at the same time maintain a low dose to the normal liver that's around it. So similar to chemo embolization, we enter that femoral artery in the right leg usually, and go up and place that catheter into the liver. And we again take advantage of that dual blood supply concept, that tumors receive the majority of their blood supply from that hepatic artery, and the normal liver receives its blood supply mainly from the portal vein. And we place a catheter into the area, and my pointer's gone, but oh, there it is. So you can see this cartoon depicts a catheter placed here and these little beads which contain beta emitter radiation, each one of them. They have a half-life of about 64 hours. So what that means is these spheres stick into the tumor arteries. Oops. And they stay in there forever. They're microscopic. They're 30 micron on average diameter. And they emit this radiation, and over the course of about 11 days, 96% of the radiation is emitted. And after about 30 days, there's no significant radiation whatsoever, but the spheres stay in the tumor forever. And the idea is the tumor shrinks and scars, and those little spheres will stay in the scar. And if you explant, if you remove or resect a portion of the liver, which happens occasionally when a patient, we can make a patient that was not resectable, not a candidate, not a surgical candidate, and convert them to a surgical candidate. And when that happens, you can take out and look at the actual spheres in the liver, and most commonly they're just in a scarred area where it's still in the liver. Here is an example of a patient that has colon cancer, and the scan on the left-hand side of the screen is the scan before treatment with these large dark spots in the right lobe of the liver, and this is 10 months after therapy. Here's another example. This is a patient who had chemotherapy with colorectal liver metastases and had Spheres treatment, and this is the lesion afterwards. This necrotic, what we call dead tissue, where you could see it was more solid before, now it's more liquefied. So another example of SIR-sphere therapy. Here's another patient. This is called a PET scan, and it's a little more difficult to understand and read, but this is the patient's heart, this is the patient's spleen over here, and this is their liver. And these dark spots are spots of uptake of this agent, which is similar to glucose. And so cells that metabolize a lot of glucose are very active. So tumor cells metabolize a lot of glucose. So they get these big dark splotches on the scan. And if you look to the right, you can see that those areas are gone. And this patient was treated with SIR-spheres. Here's another patient, also colorectal cancer. This is another PET scan. Here, the colors are inverted, and my pointer, there we go. So the white areas are areas of tumor or areas of high glucose uptake. So this is an area of tumor, this is an area of tumor, this is too. But these are the kidneys over here, and the colon and the heart. Those are all normal structures that use a lot of glucose, the bladder. So this patient had 3 liver lesions. So we used a combination here. We did radiofrequency ablation of 2 of the liver lesions. And we did SIR-spheres therapy on the larger lesion that wasn't amenable to radiofrequency ablation in the left lobe. And afterwards, this is her scan. You can see even the nice dark spot there from where we did that radiofrequency ablation, and those areas resolved. And this is the before, and this is the after. So sometimes we combine radiofrequency ablation with Y90 radio embolization, with chemotherapy. There may be different stages where the patient at one point needs systemic chemotherapy, then they get referred to me for some local regional therapy, then 2 years later, they need Dr. Kozloff, and he gives them a different type of chemotherapy, and then he needs a surgeon. So the idea is to use all the tools in the toolbox and prolong and live with this cancer. Not some of the other speakers mentioned earlier. This is something, you're not dying from this. Try to live with it, and I think that was a great statement. So you've got to use all this team approach, and that's what we try to do here at Ingalls.
Questions for Dr. Aquisto?
How frequently or how many radiofrequency ablation treatments can somebody have? As a general comment.
There's no limit, so to speak. It depends on liver function and how much normal liver is remaining. So it goes back to the comments Dr. Kozloff had mentioned about, for a normal person without cirrhosis, you really need about 30% liver volume in order to maintain function enough to live. So it's different. If you have cirrhosis, that's a total different ballgame. But as long as you're maintaining enough liver present, you could have as many as is tolerated. Yeah.
Does it regenerate? The liver doesn't regenerate?
It does. It definitely does. Yeah.
So
it definitely
if
does.
you had an ablation and it's been a number of years, there's odds are that you may have regenerated?
Absolutely.
Okay.
Yeah. Absolutely.
What determines between when you have the chemo versus the radiation feeds? What would make you choose one above the other?
Yeah, that's a great question. So certain cancers respond well to chemo, and they've been tested that way. For example, primary liver cancer tends to respond very well to to the transarterial chemotherapy. It also responds very well to the Sursphere therapy too. So certain cancers do not respond well to the chemotherapy. Colon cancer tends to be a bit resistant. Sometimes it works, most of the time it doesn't. So the Surspheres are an FDA-approved product specifically for colon cancer, and we use them off-label to do other treatments.